Hi, my name is Zainab Yassin. My seminar today about management of post-operative bleeding. Bleeding disorder is changes in ability of blood vessels, platelet, and coagulation factors to maintain hemostasis. Uncontrolled and persistent bleeding can occur in some healthy patients after dental extraction. Therefore, it is still important to achieve proper hemostasis in all patients during oral surgical procedures so as to prevent excessive postoperative blood loss. Normal mechanism of hemostasis is a complicated process involving vascular phase, platelet, and coagulation phase. Vascular phase begins immediately after surgery or injury and involve vasoconstriction in the area of injury by endothelium, like we see in this diagram. Platelet phase. Platelet adheres to the damaged surface and form a temporary plug. It begins seconds after surgery, and the platelet vessel walls become sticky. Coagulation phase has two separated pathways, the intrinsic and extrinsic pathway. Fibrinogen to fibrin is complete. The conversion of fibrin tightly binds the platelets to form a clot, as we can see in this video.
Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7, finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets.
Hemostasis dependent upon vessel wall integrity, adequate numbers of platelet like immune thrombocytopenia, proper functioning platelet like von Willebrand disease, adequate level of clotting factors, and proper function of fibrinolytic pathway. Bleeding in oral surgery. The hemostasis following oral surgical procedures can occur due to local or systemic causes. In healthy patients, the postoperative bleeding is mainly due to local causes. The local causes is either from soft tissue or bone. Local causes of soft tissue, it's either arterial, venous, or capillary. Arterial bleeding is bright red and spurting in nature. The arteries in the soft tissue and at risk during oral surgical procedures, like the greater palatine artery in the posterior portion of the heart palate, and the buccal artery lies lateral to the retromolar pad. The venous blood is dark red in color and flows steadily and heavily, especially if the vein is large. Capillary bleeding is bright red in color and is more of a minimal O's. Local bony causes of bleeding originates either from nutrient canals in the alveolar region, central vessels like inferior alveolar artery, or from central vascular lesions like hemangioma or vascular malformation. Systemic causes of bleeding in oral surgery like hereditary condition such as hemophilia, von Willebrand's disease, or patients with thrombocytopenia, leukemia, or uncontrolled hypertension. Other systemic causes like patient with a history of prosthetic heart valve replacement, stroke, or other that has oral anticoagulants like aspirin or warfarin. Types of bleeding is primary, reactionary, and secondary bleeding. The primary bleeding occurs during the surgery as a result of injury. and this type is really normal and can be controlled easily. The reactionary bleeding occurs within a few hours after surgery, and it results from coagulation failure. The secondary bleeding occurs after 7 to 10 days after surgery. This type is occurred due to partial division of blood vessel in combination with infection of the wound, and is not very frequently encountered after our surgical procedure. The management of primary bleeding in normal patient by pressure swab, suturing ligation, and electrocautery, hemostatic agents like bone wax, and use of vasoconstrictors in local anesthesia. The local measurement synthetic materials are commercially available that are used locally for achieving adequate hemostasis, like surgical oxidized regenerated cellulose, gel foam with activated thrombin, Avitene microfibrillar collagen, etic collagen, packed collagen, tranexamic acid. We can see in this clinical picture the irrigation of the wound by tranexamic acid, then suturing the wound. Management of reactionary bleeding in normal patient involve proper examination and identify if the bleeding is from bone or soft tissue. If it's from the bone, we can use bone wax, gel foam, or it's from the soft tissue by ligation, cauterization, surgical and suturing of the wound is carried out. The management of secondary bleeding in normal patient involves the removal of any debris from the wound surface that promotes the infection of the wound, and identify the source of bleeding and treat as would be done in a patient with secondary bleeding, and use of surgical stents. Hemostasis. There are 4 important steps in hemostasis: is construction of vessels, plaque formation, clot formation, and fibrous organization of clot. Thank you very much.